Hello student, welcome to class. So a small YouTube session as you know. So first of all just let me know whether I am audible to you or not. Just let me know whether I am audible or not. Okay, right. Okay, thank you very much. Thank you so much. Now we are going to discuss some of the typical PGI type of MCQs. That means all of you know that multiple answer can be possible, okay, or single answer can also be possible. So let's try. Okay, so first question in front of you, try to answer. I will give some time to answer. First MCQ is here. Very easy question. So first MCQ is easy one. Your question is which of the following is true about body water, right? So look at the option. So option number 1, A, true or false, then second, third and fourth. I'll just wait for a few seconds to answer, right? Anyone can answer. So first option, water constitutes 60% of body weight. True or false? This is true or false? Yes. Water constitutes 60% of body weight. True or false? Obviously, this is a true statement. It's a true statement. No. Okay. If your body weight, suppose 70 kg, that's the body weight of an adult person, right? Yes, it's a true. Yes, you have already written. Okay, Dr. Saptarshi, you have already written. So 42 liter is the water present in his body if the body weight is 70 kg, because 70 kg, if I take 60%, then 42 liter. Okay, so this 2 is not looking nice, so I'm writing, so this 42 liter, right? So this is a true statement. Second, now I will expect an answer that whether this option B is a true or false statement. This is not that simple. Look at the option. Okay, so I'm giving you some time. By the meantime, I'm writing something here. Don't look at here, you try to answer. Try to answer. So option number 2, it's a true or false statement. It's a false statement. First of all, I'm writing it's a false. Now if I ask you what should be the percentage here if it's become a true statement, if it become a true statement, then what will be the percentage in this question? Suppose this is a NEET PG question, single based question, that plasma volume constitute that percentage of your total body weight. Okay, a percentage, how much percentage will be here if it is a true one? Okay, now false. Okay, very good. Anaya, Dr. Abhijit, you have given this is a false statement. Okay, now I am saying what should be the percentage here to be a true statement. Right, okay, 5% approx. Okay, so plasma volume, please remember plasma volume is 5% of body weight, but this is not the question here. This is 5% of body weight, but see here, plasma volume constitute 10% of what? 10% of total body water. Please note down the statement, very important. So now look at here what I have done here to make you understand. The total body water is 42 liter, right? 1/3 is the ECF and 2/3 is the ICF. So if I divide it into percentage, then we know this is nothing but 14 liter. So this is nothing but 14 liter and this is 28 liter, right? Then we also know that this ECF is divided into, again, 1/4 will be in case of plasma and 3/4 will be in case of interstitial fluid. Very simple, we all know this. So if I say this is 1/4 of 1/4 is the plasma, means 1/4 of ECF. So 1/4 of ECF means 14 liter, the 1/4 of 14 liter. So 1/4 of 14 liter will be 3.5 liter here, and here 3/4 of the 14 liter will be 10.5 liter here. So getting my point. So what I mean to say here that plasma is 1/4 of ECF. But if you take plasma with respect to body weight, then it is 5% of the body weight. Please note down. So it's a 1/4 of ECF. That means 1/4 means 25% of ECF. So I can also write down like this, that plasma is 25% of ECF. Please don't make mistake. Very, very simple thing. But if I ask you plasma is how much percentage of body weight, then your answer is 5% of body weight. Then if I ask you what percentage of ECF, 25% of ECF. That means 1/4 of ECF. Now 1/4 means if the body weight of the person is 70 kg, I have already told here, then plasma will be 3.5 liter. Now look at the statement again. Now look back at this statement again. So here the statement is plasma volume constitute 10% of total body water. So in this example, how much is the total body water? 42 liter. And how much is the plasma? 3.5 liter. So 3.5 liter upon 42 liter, if I take percentage of this, then it will be around 8.3%. That means I mean to say that plasma is 8.3% of total body water. So this 10 is wrong number. If it is 8.3%, then it will be a correct statement. Please note down this thing. Okay, so please go through this thing again, because it's looking like very simple, but if you don't be cautious in exam, there is huge chance that you may make mistake. Okay, so again I am saying that with respect to body weight, plasma is 5% of the body weight. With respect to ECF, plasma is 25% of ECF. But with respect to body water, plasma is 8.3% of total body water. These three things we have discussed here, so try to remember. So option number B is also a false statement. Then ECF volume, then third statement, ECF volume can be determined by dilution method. Yes, it's a true statement. It's a true statement, right? And 10% is intracellular water. So this is again a false statement. So which of the following are true about body water? So obviously our answer is A is my answer and C is my answer. Okay, so in this MCQ my answer is A and C. They are the correct answer. Everybody, any confusion here? Okay, I hope there should not be any confusion, because this is very, very simple thing. Okay, now I am going to the next question. What are effect of membrane when extracellular concentration of potassium, ECF dilution? Okay, any kind of body water can be measured by volume dilution principle. Okay, that is the volume dilution method. Okay, so any kind of ECF volume can be determined by dilution method. Yes, dye is injected and that is measured by dilution method. That dye will be diluted in the body, and what is the concentration of the dye, that is measured. Okay, that is the volume of distribution or dilution method, right? So this is also a true statement, right? Now coming to this question, what is or are the effect of membrane when extracellular potassium is decreased? Extracellular potassium is yes, inulin. Yes, inulin is the dye. There are also other also, like mannitol can also be used, sucrose can also be used for the ECM measurement. That is be diluted in your body. So volume of distribution method or dilution method, that can be said. Okay, so inulin can be used. That is the best for ECM measurement. Even blue is for plasma. Even blue is for plasma. Even blue and albumin tagged with 125, that is for plasma. Okay, I have taken another session for AIMS examination. There I have given one table, complete table for all of this dye, that what dye should use for which measurement. Please listen that session in it is there. I have taken that session 2 days ago. Okay, so please search that session that on AIMS session. That there I have discussed all of this principle of body water measurement. Okay, now coming to this question, that what is the effect on membrane when the extracellular potassium is decreased? Right, so here extracellular potassium concentration is decreased. So always you have to remember like that. Suppose this is the cell, we all know that RMP of the cell, okay, listen carefully, RMP of the cell is mainly determined by potassium leak channel. So what I told, RMP is mainly determined by potassium leak channel. Yes, you are giving some answers, see, okay, potassium leak channel, right, potassium leak channel. So whenever the cell is in a resting condition, what will happen, the diffusion of potassium outside and the diffusion of potassium inside, both will be in equilibrium. Equilibrium means the net movement of potassium through this channel is zero. Now whenever due to some problem, whenever your extracellular potassium is reduced, like for example here, that extracellular potassium is decreased, hypokalemia, what will happen, this movement of potassium from inside to outside will be increased because outside potassium concentration is less. So if the movement of the potassium from inside to outside is more, that means I can say cell is losing, there is loss of some extra potassium from the cell. If the cell is losing potassium extra, so positive charge is going to be lost from the cell. If the positive charge is lost, then cell interior will be more negative. That means I can say there will be hyperpolarization of the cell. That means RMP will be in a hyperpolarized. Why? Because outside potassium has been decreased. Because of the outside potassium decrease, this equilibrium, okay, equilibrium will be new equilibrium, there will be a new equilibrium, and in the new equilibrium some excess potassium will go out of the cell, that means cell is losing some potassium. So if the cell is losing some potassium, interior will be negative. So what I'll choose here, so I'll choose that increase negativity of the membrane. So first answer is this is my first answer, okay, increase negativity of the membrane. Now increased negativity of the membrane is also known as increased magnitude of the RMP. Yes, you are correct, okay, you are correct, your answer is correct. So please remember, increased negativity of the membrane, that is the hyperpolarization, is also known as increase in RMP, right, increase in RMP. So this kind of question is given multiple times, okay. Suppose I am saying that rather than hypokalemia, suppose your question is hyperkalemia is your question, hyperkalemia, then what will happen, extracellular potassium is more than normal. So again I will imagine like that, suppose this is my cell and RMP of this cell is mainly due to leak potassium channel through which potassium is going out and in. Now whenever the outside potassium is more, whenever your outside potassium is more, this movement of potassium from in to out will be less. If the potassium movement is less, then more potassium is staying here, more potassium will stay inside the cell. More potassium means which kind of charge will be little extra inside the cell, positive. So cell will be in a depolarized condition, partial depolarized condition, and depolarized is also known as decrease in RMP, right. So this is the condition of hyperkalemia, and hypokalemia we have already discussed. So in this question my answer is B and C, right. Okay, so now I am moving into the next MCQ. Again, this is very typical of PGI Chandigarh MCQ, and this is very important, okay, very important. Now look at this third MCQ, try to answer. Whoever is preparing for the AIMS entrance examination also, even for JIPMER and obviously for PGI, this question is very crucial. Increased velocity of conduction in a nerve is favored by. A, increase capacitance. Okay, I am waiting. Decrease capacitance. A, D, decrease resistance. Yes, so at least whatever you know that answer A and D. Okay, I'm getting some good answer. Very good, I'm getting some good answer. Okay, so one of the answer is increased diameter. Okay, I think there is no confusion in this, that increased diameter will increase the conduction velocity. And decrease resistance, obviously if there is decrease in resistance of the exoplasm, then there will be increase in conduction velocity. And if there is decrease in capacitance, then also it's a answer. Now look at the discussion please. Answer is not the A. Increase capacitance will not be the answer. Okay, so suppose this is a neuron. Now listen, before doing any confusion, listen what I am saying. So first of all, what is the thing? Suppose this is a neuron. Suppose this is a neuron. We know that neuronal action potential is because of entry of sodium ion inside the cell due to voltage gated sodium channel. Well and good. Now whenever there is entry of sodium inside this cytoplasm, what will happen? This sodium will move through the cytoplasm or exoplasm to the next node of Ranvier. So it is reaching here. In the next node of Ranvier, right? Now whenever it is reaching in the next node of Ranvier, it will again open up further voltage gated sodium channel because of this depolarization, and that will leads to further entry of sodium, and another action potential will be produced here. So I can understand like that action potential is jumping from one node to another node, but basically it is not the action potential which is jumping, it is the sodium which is traveling through this cytoplasm. So what I have to do if I want to increase the conduction velocity of this sodium transmission? What I have to do? I have to decrease the resistance of this cytoplasm. So first condition to increase the conduction velocity. So conduction velocity will be high if there is decrease in exoplasmic resistance. Now how to decrease the exoplasmic resistance? You increase the diameter of this neuron. So that's why we know whenever we increase the diameter of this neuron, what is going to happen? This resistance is going to decrease, and that's why conduction velocity will be high. There is no confusion. Now second thing, whenever this sodium is traveling from one node to the other node through the cytoplasm, there is always a chance that the sodium will leak out from the cell like this. Now if it is leaking out from the cell more and more, what will happen? There will be less amount of sodium in the next node of Ranvier, and if it is less, then second action potential may not generate in the next node of Ranvier. So what I have to do? I have to prevent the loss of this sodium by giving some insulated covering on this membrane, and this covering is nothing but myelin sheath. That's why second option, if you increase the myelination on neuron, what will happen? You are preventing the loss of charges from the cell cytoplasm, and that will causes increase in conduction velocity of action potential. Okay, and that's why all of you know that if there is demyelination, what will happen? This sodium loss will be more and more, and conduction velocity will be decreased. Now whenever you are increasing the myelination, what you are doing? Note down what you are doing. Remember one thing, membranes acts as a capacitor. What do you mean by capacitor? Capacitor consists of two plates like this. So two parallel plate will be there, and this is similar to the structure of cell membrane. Why? Because we know that cell membrane is composed of lipid bilayer. So these are the lipid bilayer. So membrane can behave like a capacitor. Now whenever I am giving myelination, what I am doing? I am increasing the thickness of the plate of this capacitor. Whenever you increase the thickness of one of the plate of this capacitor, what happens to capacitance? there will be decrease in capacitance of the membrane. That's why please remember, increase in myelination means there is decrease in capacitance of the membrane, and because of decreased capacitance, the conduction velocity will be increased. Okay, so please remember, there is a formula that conduction velocity of action potential is inversely proportionate to resistance and capacitance of the membrane. Inversely proportionate to resistance and capacitance. Capacitance, it is the capacity to store charge. It is the capacity to store charge. That is the principle of physics. Okay, the capacitor, the principle of physics, it is the capacity to store charge. So whenever there is increase in thickness, the capacitance decreases. And what is the relationship with the capacitance and conduction velocity? I have written the relationship here. Conduction velocity is inversely proportionate to resistance of the exoplasm and capacitance of the membrane. Means more the decrease in resistance, okay, more will be the conduction velocity. More the decrease in capacitance, more will be the conduction velocity of action potential. This formula you have to remember. CV, conduction velocity, is inversely proportional to RC. R is the resistance and C is the capacitance. That's all. Okay, so from here 3 answers are correct. This is the discussion. Okay, so please go through this. This is very important for any kind of examination. Okay, so that's why we in book we used to read the myelination increases the conduction velocity, diameter increases the conduction velocity, but just now I told you that what is the relationship of capacitance and resistance also. Okay, right. Now this is the simplest form of question. I hope all of you will give the correct answer. In muscle contraction, all are true except. So first, this is true or false. A band remain unchanged. True or false? I am waiting. A band remain unchanged. True or false? During muscle contraction, A band is the myosin band, thick filament band. It remain unchanged. Yes, it's a true statement. Yes. Okay, just write down T or F. I will understand, because there may be. So H zone disappear. True or false? Yes, it's a true statement. I band wider. It's a false statement. 2Z line come closer. Yes, it's a true statement. So your question is except. So only one is the answer here. C is the answer, that I band is never widened. I band will be shortened, or I band can be disappear. Very good. Okay, so now all of you are giving very correct answer. So my answer is only and only C, right? Okay, thank you so much. You are giving correct answer, right? Okay, now coming to the next question. Baroreceptor stimulation produces. Okay, so what is your answer? So if I stimulate baroreceptor, yes. Okay, so you have given answer A, answer B. I'm waiting. Okay, right, A, right. Okay, B. So now you think, who will stimulate the baroreceptor? Any condition, if your blood pressure is high, then baroreceptor will be stimulated. So if my blood pressure is high, baroreceptor is stimulated. What the baroreceptor will do? Obviously it will try to decrease the blood pressure, otherwise it will be a positive feedback, but it's not, it's a negative feedback. So what the baroreceptor will do? Obviously, even if you just know this information, that BP, whenever it is blood pressure is higher, it is going to stimulate your baroreceptor. Okay, it is going to stimulate your baroreceptor. So what the baroreceptor will do? It will send signal to the NTS first, right? NTS will be stimulated, nucleus tractus solitarius. If NTS is stimulated, what is going to happen? It is going to inhibit your vasomotor center of the medulla, and through this vasomotor center, our sympathetic system is going to be inhibited, right? Apart from that, this NTS is also going to stimulate cardiac inhibitory center, CIC, cardiac inhibitory center. This is the center for vagus. Vagus is nothing but the parasympathetic, so there will be stimulation of parasympathetic. So please note down this. This is the basic, this is not the detailed version, this is the very simplest form of baroreceptor mechanism. Whenever my baroreceptor is stimulated, two things going to happen. Vasomotor center will be inhibited, so sympathetic will also be inhibited, and cardiac inhibitory center is going to be stimulated, okay, and parasympathetic will be, okay. Mary's law, what is Mary's law? BP increases, yes, inversely proportional, yes, that will be applied here, it will be applied here. So that's why answer will be, what is answer will be here? So look at the answer. Baroreceptor stimulation produces, first one is this, sympathetic is inhibited, so what will happen to the heart rate? Decrease. And what will happen to the BP? Yes, decrease. And parasympathetic is also stimulated, so parasympathetic stimulation means heart rate will be decreased, simple. And apart from that, because of this sympathetic inhibition, there will be also decrease in cardiac contractility. Very good, yes. So there will be decrease in heart rate, blood pressure, as well as decrease in cardiac contractility. These two is not possible, because if the baroreceptor is doing so, then your blood pressure will be more and more positive feedback, and that is dangerous. Vicious cycle will be created. That's not happening. Okay, so please remember this very simplest form of thing here. Okay, now I'm going to the next question. Right. Maximum difference of blood pressure occurs between, important question but simple answer. Look at the question first, then you will be able to answer. I hope all of you will be able to answer, I am sure. Look at the option, read out all the options, single best answer obviously here. Maximum difference of blood pressure occurs between, so here it is aorta and artery. No, artery and vein, arterial end, venous end, capillary, venules, venules, vein. That is my thinking. Now you look at and tell me the answer. I got one answer, yes, Dr. Sairam, you have given answer. Just I will hold on for others also. Tell me, where are others? C, yes, Dr. Moria, yes, you are correct, right. Pinarai, you are also correct. I hope I am correctly pronouncing all of your name. Please forgive me because of my pronunciation. Dr. Bindu, yes, you have given some answer, right. Venules and vein, no, yes. So answer here is C. Answer here is C, because one of this is the artery and one of this is vein, so obviously pressure difference will be very high. Now look at how to remember this. Okay, so I have taken a diagram from Genome. And in Genome it is written that average blood pressure. So look here, this curve is the detail of everything, but look at here, this is the aorta, so this coordinate is the aorta, this is the aortic coordinate, okay. Then this is the artery, then this is the arterial, capillaries, venules, vein, and vena cava. Okay, so this is the systolic blood pressure depicted here, this is the diastolic blood pressure depicted here. Okay, and this velocity relative resistance, this is a separate discussion, I am not going to do that right now. So what I will remember from this diagram, okay, I am just deleting all of this thing. So note down the average blood pressure at the level of this aorta and artery. The average blood pressure at the level of aorta and artery means in this zone, I am writing here, on an average this is 90 millimeter of mercury, okay, given in Genome. Then the average blood pressure at the level of these arterioles, okay, in this zone, at the level of this arteriole, see here the blood pressure is dropping, systolic blood pressure and diastolic blood pressure follow this line, they are dropping, means there will be less blood pressure at the level of arterioles. What is the pressure here? On an average this is 60 millimeter of mercury. Now we all know that arterioles are the resistance vessel, that's why you can see here this is the resistance of different vessel. So arteriole resistance is maximum, okay, that's why we know that arterioles are known as the resistance vessel. And because of the huge resistance at the level of arterioles, what will happen? the blood pressure will drop to a very low level in the next level of blood vessel. That means after the arterioles, what is the blood vessel? That is the capillary. So at the level of capillary, from this 60 millimeter of mercury, the blood pressure will suddenly drop to 25 millimeter of mercury. Okay, and then there is further drop of blood pressure. We can see here there is further drop of blood pressure when I am moving towards the venules, vein and vena cava. So what is the average pressure at the level of these venules? This is 15. At the level of vein, this is 12 millimeter of mercury, and at the level of vena cava, this is 3 millimeter of mercury. So please remember this average blood pressure. Now in my question, if you look at the option, then you will find out that the difference between this artery, okay, sorry, this C is not the answer. I have not seen this thing. The answer is B, femoral artery and femoral vein. The difference between the femoral artery and femoral vein, because all of you have given answer C now, so I become confused. Okay, no, this is not the arterial vein, this is not the venous vein. The maximum difference will be femoral artery and femoral vein, because at the level of artery is blood pressure is 60 millimeter of mercury, and at the level of vein this is 12 millimeter of mercury. So difference between this artery and vein is maximum. So that's why, please, again I am going to the answer. The answer will be B, not the C. All of you has given answers, so I become confused. So arterial end and venous end is not the answer. Okay, arterial and venous end difference will be very less, because we can see here that at the level of arterial end, so this is the capillary, so arterial end and venous end, the difference is not very significant. Okay, see here the difference between this arterial end and venous end, and at the both end of the capillary is not very high. But if you take the difference between these arterioles or artery, okay, or this vein, then that will be the maximum. Yes, why not C? I told you here. Okay, just now I told you that if I take the arterial end and venous end, okay, that is nothing but on both side of the capillary. Look at the difference, not very high. Okay, so blood pressure at the level of artery is around 60. It is dropping towards the capillary one end, and it is 15, means drop is mainly this difference is basically on and around 25 minus 15, on and around 10. But if you take the difference between artery and veins, that is very significant difference, 90, and this is 12. Okay, so that's why answer, the best answer here is the femoral artery and femoral vein. Now understood or not? Okay, always the difference between artery and vein will be always maximum, because the significant drop of blood pressure occurs at the level of arterioles. If you just remember this, that significant drop of blood pressure occurs at the level of arterioles, then obviously the difference will be maximum between artery and vein. Okay, arterial end and venous end is not the answer. Got it? Okay, thank you. Now look at the next question. Increase airway resistance. I am saying this question can be very crucial, not for the PGI. It is also a crucial MCQ for NEET exam also, as well as for AIIMS entrance examination also. Increased airway resistance are caused by increased airway resistance. Okay, so they are asking about the resistance of airway. Right, resistance of airway. So always we know that resistance is calculated based on Poiseuille's-Hagen formula, which says 8 eta L pi r to the power 4. This is the formula. So it's basically the resistance of any tube depends on the radius as well as viscosity and length of that tube. I have given one hint. Now tell me the answer. What are the correct answer in this question? D1 answer you have given. D, increase airway resistance. Please guys, think. Resistance, if the radius is increased, then what will happen to the resistance? Decreases. High lung volume. So high lung volume means, suppose I am going for the TLC. What will happen if I take a deep inspiration Deep inspiration, lung volume is very very high, my lungs are expanded. Now when my lungs are expanded, obviously the bronchioles will be dilated. So in this condition, what will happen to the bronchioles and bronchi? So bronchi, bronchioles will be dilated. If it is dilated, what will happen to resistance? Resistance will decrease. How can you say this is the answer? No. The resistance will be minimum when the total lung volume is at TLC. Okay, think again. B and C. Okay, now I am clearing this C. Please remember, dense air, density, and this eta. This eta is viscosity. Please note down. This is the basic concept. Viscosity and density, they are not the same. Viscosity means it is the thickness of the air or thickness of fluid, and density means how many particles are there in a unit volume. Density of air के साथ there is no relationship or there is no direct relationship of this airway resistance or airway flow. That is written clearly in books, but it is related with the viscosity. So density or dense air is not going to be the answer here. So neither the D is my answer, neither the C my answer. Now tell me again, think and tell me the answer again. Forced expiration. So what I am doing forceful expiration. What is happening to my lung volume? What is happening to my lung volume? Low lung volume during forced expiration. So basically you are compressing your lung during your forceful expiration. So basically these two options are almost similar. The diameter of the bronchi and bronchioles will be decreased. The diameter of the bronchi and bronchiole will be decreased. So please remember this. So what will happen? Obviously both will be my correct answer. So this is my correct answer, this is my correct answer. Both will be the correct answer, because forced expiration means there will be compression of the lung, so there will be reduced in the diameter of bronchi and bronchiole. Low lung volume means again same thing. If you do a forceful expiration, you are going for a small volume which is nothing but the residual volume. So what will happen? The diameter or the radius of the bronchi and bronchiole will be reduced. So what will happen to the resistance? Resistance will be very very high. So that's why I am saying the answer is A and B. Now please guys remember this graphical representation for the NEET PG examination, because this has been asked in the NEET exam already. So look at what I am drawing. So this is the lung volume, x-axis, and y-axis is the resistance of airway. Now you can see the resistance of airway is minimum here. So this is the minimum point. What is the lung volume in this condition? TLC. TLC. That means when your lung is fully expanded, the dilation of bronchi and bronchiole is maximum. So resistance is minimum. So if the question is minimum resistance of airway at which lung volume? TLC. On the other hand, maximum resistance. Okay, maximum resistance means my lung volume will be minimum. Minimum lung volume that is possible is residual volume. That means whenever you do a forceful expiration, the small volume which is present in the lung is the residual volume. At that condition there will be severe compression of bronchi and bronchioles, and that's why resistance will be maximum. So I am writing here resistance is maximum at residual volume and resistance is minimum at TLC. Please don't forget this information. This is a crucial for any kind of examination. And there can be another MCQ, that maximum airway resistance is at which level? At the level of bronchi or bronchioles? If my question is this, bronchi or bronchiole, your answer will be medium size. Your answer will be medium size bronchi. Okay, not the bronchioles, please remember, if the question is maximum airway resistance, it is not at the level of bronchioles. Okay, there is an explanation for this, but please remember medium size bronchi. Okay, you may think that bronchi, and why not bronchioles? Because bronchioles are the smallest size. Then you have to think that bronchioles numbers are very very huge and they are in a parallel circuit. So whenever any kind of resistance you arrange in parallel circuit, the total resistance of that segment decreases. That is the principle of physics, total resistance of a parallel circuit. Okay, so you all know lungs जो bronchioles होता है, they are going to divide like this. So whenever you are going for the smaller division at the level of bronchioles, what is happening? More and more number of parallel division is going on. That's why the total resistance at the level of bronchioles are not very huge, less. That's why I told you the maximum resistance of airway is not at the level of bronchioles, it is at the level of medium sized bronchi. Please remember, this is also for the NEET or AIMS type of examination. Clear? I hope you got the concept. Clear na? All of you, whoever is listening. Yes, that is the formula for the case. Okay, that is the formula for the calculation of the parallel circuit resistance. That's why the total resistance will be less. Okay, very good, Dr. Pinarai. Right, now look at this question. So here the question is, this is a simple question, simplest form of question. So here the question is, functional residual capacity of the lung is defined as, functional residual capacity of the lung is defined as, tell me everybody, FRC, they are asking about the FRC, right? Okay, so ERV and RV, so this is true statement, yes. Is anything is true? Answer is no, only and only C is the answer. So volume expired after normal expiration, volume no, A is not the answer. Remember what is written here, volume expired after normal expiration. So this is what, volume expired after normal expiration. Even if you expire forcefully after normal expiration, so which volume will go out of the lung? That is the expiratory reserve volume they are saying here. Okay, so I have kept one diagram here for your understanding. So this is the ending point of the normal expiration. This is the ending point of the normal expiration. If you do some more forceful expiration, the extra air which is going out is the ERV. So the first statement is the ERV, that the volume expired after normal expiration is the ERV. Okay, ERV. And the volume which is still remaining after this expiration is the residual volume. Please note down, the volume which is still remain, if the question is like this, that volume remain in the lung after forceful, not the normal, after forceful, then your answer will be residual volume. Okay, volume remaining after forced expiration, volume remaining after forceful expiration, this is about the residual volume. Volume remaining in the lung after forceful expiration, this is about residual volume. And option D, total tidal volume plus volume inspired forcefully, tidal volume plus volume inspired forcefully, this is known as inspiratory capacity. Okay, tidal volume plus volume inspired forcefully. So this is the thing, this is my tidal volume and this is my inspired volume forcefully. So what is the combination of these two? This is known as the inspiratory capacity. So this is the answer. So here only single based answer, that FRC is nothing but ERV and RV. Now I am going to the next question. Okay, now the question which is in front of you, this is most toughest question in my discussion. This is most toughest question, most. Okay, now even the normal books has not given the answer of this question, and this is typical of the PGI. In Triparty, if you open pharmacology Triparty, then you will find out it is written that transmission at the level of autonomic ganglia, sympathetic and parasympathetic ganglia, is very complex, but they have not described what happens at the level of autonomic ganglia. So please note down my discussion, then I will come to the answer at the end. Okay, so suppose this is presynaptic neuron. Okay, please everybody note down at the discussion, please note down the discussion, then we will come to the answer. So suppose this is the autonomic ganglia, autonomic ganglia, right? So it may be sympathetic or parasympathetic. So in so if it is parasympathetic or sympathetic, what is the neurotransmitter, whether it is sympathetic or parasympathetic? Ganglia means always the neurotransmitter is acetylcholine, right? Okay, hold on. Okay, hold on. GnRH, you are giving one of the very crucial answer. So ACH is the neurotransmitter, acetylcholine. So What is the receptor present here for the acetylcholine? Now I will expect an answer from your pharmac knowledge, that what is the receptor for this acetylcholine at the level of autonomic ganglia. Hold on, I am expecting an answer. What is the receptor? Everybody try to answer, whoever is there. What is the receptor for this acetylcholine at the level of this autonomic ganglia? Simple, all of you know this. Yes, nicotinic. Okay, so yes, both must. Oh my god, Obvijit, very good, very good. Okay, yes, I was expecting this answer, that nicotinic neuronal variety. Nicotinic. Okay, so first answer will be nicotinic, and everybody is correct. Everybody is correct that it can be of muscarinic also. It can be of M2 also. It can be of M1 also. Very good, excellent, excellent. So it can be of M1 also. NN. So the first and foremost important is the NN, right? NN, nicotinic neuronal variety. So what will happen? Now listen, now be careful what I am saying. So whenever acetylcholine attached to this receptor, there will be entry of sodium. So sodium means there will be depolarization of this neuron. So if I plot the change of this membrane voltage here, what I will find out? So this, look at this plotting. So x-axis is the time axis and y-axis is the voltage change of this membrane, voltage change of this membrane. So I am writing here, this is membrane voltage change, right? Okay, hold on. Okay, yes, I know, very good, excellent. So whenever there is depolarization due to this sodium, so what will happen? Suppose this is the point where the acetylcholine has attached, there will be a depolarization, okay, but this depolarization will not last for longer duration if the acetylcholine is not sufficient. This kind of depolarization is known as EPSP, and this is fast EPSP because it is occurring immediately, almost immediately after acetylcholine attachment. And this EPSP, this fast EPSP, is due to this NN receptor, right? NN receptor. Then what will happen if this M2 receptor is stimulated by acetylcholine? What will happen? There will be exit of potassium from this cell. Exit of potassium from this cell. So exit of potassium from this cell, again your understanding is that cell is losing positive charge. So what will happen? There will be negativity. If the negativity is there, then membrane voltage will go down. Okay, hyperpolarization is occurring. So this kind of hyperpolarization is known as IPSP, inhibitory postsynaptic potential, and because it is occurring after some point of time, this is known as the slow IPSP, and this slow IPSP is occurring due to which receptor? M2 receptor. So please remember, M2 receptor produces slow IPSP. Then if your M1 receptor is stimulated by acetylcholine, what will happen? This M1 receptor is normally permeable for potassium, but if the M1 receptor is stimulated, what will happen? There will be decreased exit of potassium, decreased efflux of potassium from the cell. If the potassium efflux decreases, there will be more positivity inside the cell. More positivity means, again I will get a positive potential here. This potential will be again EPSP. Okay, so this is again a EPSP, but this EPSP is slow EPSP. Obviously the first EPSP I have given name first EPSP, now here I have given slow EPSP. Now after this slow EPSP also, there can be another EPSP after long point of time. This is known as the late slow EPSP. It is occurring after very long duration of time. This late slow EPSP is due to some other receptor which are occasionally present, particularly in case of sympathetic ganglia, So this is late slow EPSP is due to various peptides receptor. What are the peptides that I should remember? Substance P, right? Enkephalin, right? GnRH, particularly LH releasing hormone, gonadotropin releasing hormone. These are the peptides that I can remember, that substance P, enkephalin, GnRH. These are the peptides which can also produces this late slow EPSP, particularly at the level of sympathetic ganglia. Late slow IPSP is not there. Late slow IPSP is not there, and late slow EPSP is not possible in sympathetic ganglia, parasympathetic ganglia. It is only for sympathetic ganglia, right? So now look back at the question. Here the question is slow and this is the IPSP. So this is the slow and IPSP. So IPSP, what will be my answer? What will be my answer? Neither this GnRH is going to be answer, neither this adrenaline, neither this dopamine, neither this nicotinic cholinergic and muscarinic cholinergic. So what I'll choose? Okay, so nicotinic cholinergic. What is the answer here? A or B? Now tell me the answer. Yes. So nicotinic cholinergic will produce EPSP, and that is which variety? Fast EPSP variety. And this is my answer. This is my answer, B. So GnRH will produce what? This will produce late slow. Okay, late slow EPSP. Dopamine is not the answer in this question. So please remember this beautiful question. Very, very good question. Now for your understanding or for your remember what I have done, I have given one table here. Okay, whatever I told, I have given a table here. Note down this table quickly. So EPSP, slow EPSP and late slow EPSP. So this is the EPSP which is known as the fast EPSP. Okay, why this is known as the fast? The latency is very, very less. I told you that this EPSP occurs immediately, almost immediately after acetylcholine attachment. So EPSP latency means, what is the latency? Latency means after acetylcholine attachment, how much time point it is taking for generation of the positive voltage. This is 0.5 millisecond, and this is due to influx of which one? Sodium ion. It may be also due to influx of calcium ion. It can seen in any kind of autonomic ganglia everywhere. Okay, now look at the slow EPSP. Slow EPSP is latency is long, that's why this is known as the slow. And this is due to which one? Potassium. We have seen that slow EPSP is due to which receptor? M2 receptor. So I told you M2 receptor means what will happen? There will be this is not due to M2 receptor, this is due to other receptor, but there will be decreased potassium efflux. But slow IPSP here is due to M2 receptor, and this is due to potassium efflux, that we have already discussed. And late slow EPSP we have also discussed. This is also due to potassium ion, but I told you what are the receptor? Various peptides receptor are there for this EPSP. And where this late slow EPSP occurred? Sympathetic ganglia. So parallel to this EPSP, IPSP is also there, fast IPSP and slow IPSP. So the previous first one, this is the fast IPSP, okay, and this is the slow IPSP. First IPSP is due to calcium influx and slow IPSP is due to potassium efflux from the cell. Okay, and the site where this EPSP or IPSP is seen, if you look at the slow EPSP, it is seen in autonomic ganglia, cardiac muscle also, smooth muscle also. Same is also written in case of slow IPSP, cardiac muscle, autonomic ganglia, smooth muscle, etc. And late slow IPSP is not possible, it is not there. Okay, so try to remember this table if you are particularly preparing for the PGI type of question, right? So this is all about the question. Now coming to the last question for today. Try to answer, dear student. So all of the following are true about renal physiology except. So you tell me whether this is correct or not, true or false. Sodium absorption occurs in DCT, true or false? First option, true or false? First statement, this is true or false? DCT, sodium absorption, obviously this is true. Sodium absorption occurred in DCT. What is the problem? It is there. Sodium chloride symporter is there, which is blocked by thiazide. Why this is false? Serum. Okay. So this is true. Okay, sodium absorption occurs in DCT, distal convoluted tubules. Yes, there is sodium absorption. Sodium chloride symporter is there. Potassium is both secreted and absorbed. This is also true. Remember, potassium is the only electrolyte which can be secreted or it can be reabsorbed. Please remember. Okay, sodium chloride channel. Yes, because of the sodium chloride channel, this is true. Second, potassium is secreted as well as absorbed in tubules. Yes, this is true. Glucose is absorbed in DCT. No. This is false statement. almost 100% glucose is absorbed in the proximal only, and almost 100% glucose occurs in the proximal tubule, right? Hemoglobin is not excreted as it is a large molecule. It's a false statement. We know that hemoglobin can be excreted if the hemoglobin is freely present in your blood. Like for example, intravascular hemolysis, you know that if there is intravascular hemolysis, so there will be hemoglobinuria. Yes, that's why this is false statement. Amino acid are absorbed in collecting duct. Yes, that's a false statement. Amino acid are absorbed 100% at the level of proximal tubule. So question is all are true except, so my answer is this and this, right? So this is, yes, like in PNH, paroxysmal nocturnal hemoglobinuria. Yes. So if you want to remember, please remember this hemoglobin molecular diameter, okay, it is just lesser than albumin molecular diameter. Hemoglobin molecular diameter is 3.25 nanometer. And what is the albumin molecular diameter? Albumin molecular diameter is 3.55 nanometer. Okay, we know albumin can also appear in the filtration if the negatively charged is vanished. If the negative charge of the basement membrane is vanished, then albumin can also appear in the urine. And obviously, if the hemoglobin diameter is lesser than albumin, why not it will appear in the urine? It can appear in the urine, but this is not due to the diameter, because hemoglobin remain inside the RBC. It is not filtrate normally. But if it is releasing from the RBC, like for intravascular hemolysis, any cause of intravascular hemolysis, okay, then it can appear in your urine. So that is all about today's discussion. Now just for the promotion and to give you information that I am taking 2 parallel session, okay, in Unacademy platform. One is the NEET PG course, okay, and here I am taking the whole physiology discussion. The course is for 6 months. I will be finish my physiology discussion within first 3 months, okay. There are 4-hour class per day, okay, and I will finish up the whole physiology in this session. And this revision course, this is course for only 1 month. No, molecular diameter is 3.55 nanometer albumin. If it is 7 nanometer, it will never appear in the urine. Check once again, okay. It is not 7 nanometer, it is 3.55 nanometer. Check once again, it is 3.55 nanometer. Boron textbook of medical physiology, okay, there it is clearly written that molecular diameter is not 7 nanometer, it is 3.55. No, hemoglobin will not be blocked by negatively charged molecule, okay. Now, and sir, kindly explain why there is no tetany in cardiac muscle. Okay, that takes a little long discussion, but the answer, one line answer is because the action potential duration of cardiac muscle is very, very long. Tetany cannot occur. Action potential in case of skeletal muscle is very, very short, so you can give multiple stimulation with it quick succession. But because the action potential duration of myocardium is very long, you cannot give quick succession stimulus, because you know if you want to produce tetany, you have to produce multiple quick successive stimulus, but that is not possible in myocardium because the action potential duration is very long. So if you are giving multiple stimulation within that long period of action potential, it will fall in the refractory period, and that will never produce second contraction, and tetany will not be produced, okay. It will take some time to explain. It's not possible in this discussion, but that is in brief. Yes, more refractory period. If the action potential duration is more, so obviously the refractory period will also be more. But for the production of the tetany, what I have to do, I have to stimulate multiple times, okay, in quick succession. But for skeletal muscle, the action potential duration is very, very short. For skeletal muscle, the action potential looks like this, okay. So you can easily give one stimulus here, again another stimulus here, and there will be tetany generation. Now the multiple question are coming, and that question are different. Sir, large nerve fiber, exoplasmic and membrane resistance. Obviously, if the diameter is large, then exoplasmic resistance will be less. But membrane resistance, please remember, I have not talked about the membrane resistance. There is something called transmembrane resistance. Probably you are asking this transmembrane resistance, okay. Transmembrane resistance, if this is the cell membrane and suppose this is the myelination, then transmembrane resistance means if I measure the resistance across this membrane, then that is known as the transmembrane resistance. Okay, in case of myelinated neuron, obviously more the myelination, more is the insulated material, so what will happen to the transmembrane resistance? It will be high. Okay, so please remember, if it is a myelinated nerve, transmembrane resistance will be higher. Transmembrane resistance depends on the insulated thickening of the membrane, but exoplasmic resistance depends on the diameter of the neuron. If the diameter is more, exoplasmic resistance will be reduced, but if the myelination is there, transmembrane resistance will be higher. Now you got it?